All right, let's get right into it. As a senior medical examiner and attending dermatopathologist, I'm taking you through a hyperdense, zero-filler audit of the absolute most fatal execution gaps in dermatology. Today's explainer focuses on Section 87. Listen, hesitation or just relying on surface-level assumptions here, it can literally be lethal. We're going to look strictly at the data, the pathology, and the exact maneuvers you need when you're face-to-face with a failing epidermal barrier or a suspected malignancy. Let's go. Here's our structural playbook for today. We'll cover Module 1 on the epidermal cleavage plane, Module 2 on epidermal necrolysis exfoliative profiles, hidden executional pearl on volume resuscitation, move into Module 3 on melanocytic malignancy kinetics, and wrap it all up with a mandatory clinical validation drill. All right, Module 1, the epidermal cleavage plane. This is what we call the 50-50 dilemma. So, the clinical lawyer, you know the type, frequently gets trapped by generalized blistering in an elderly patient, just automatically assuming age alone confirms bullous pemphigoid. But the judge demands proof. The noise? That's nonspecific peripheral eosinophilia. Just ignore it. The actual signal here is mucosal involvement and the physical blister structure itself. Pemphigus vulgaris brings those flaccid, easily ruptured blisters and incredibly painful oral mucosal involvement. Bullous pemphigoid, on the other hand, gives you firm, tense blisters and completely spares the mucosa. To actually prove this at the bedside, understanding the Nikolsky sign maneuver is absolutely mandatory. It's the separation of the superficial skin layers with just a slight rub. If you stroke unblistered skin right next to a lesion and that upper epidermis just shears right off, boom, positive Nikolsky sign. It instantly reveals the underlying architectural failure of pemphigus vulgaris. Oh, and here's a massive mistake to avoid. Never, ever biopsy the center of a completely denuded fluid blister. You're just going to get uninterpretable necrotic debris. You've got to perform a punch biopsy at the active perilesional erythema margin to actually capture that cleavage plane. And this slide brilliantly isolates the microscopic pathology variants, the exact cellular targets we're dealing with. In pemphigus vulgaris, autoantibodies are targeting desmoglians, specifically 1 and 3, which are responsible for keratinocyte adhesion. This causes an intraepidermal split. On direct immunofluorescence, you'll see a classic net-like intercellular pattern. But in bullous pemphigoid, autoantibodies target hemidesmosomal proteins like BP180 and 230 right at the basement membrane zone. That deeper split gives a thick blister roof, presenting as a continuous linear band on immunofluorescence. Moving right along to Module 2, epidermal necrolysis exfoliative profiles, or what I like to call the exfoliative gradient. When the epidermis starts separating on a massive scale, you are on a ticking clock. You absolutely must accurately plot your patient on this exfoliative gradient. The real crucial point here is the strict mathematical calculation of total body surface area, or BSA, detachment. This exact metric completely separates Stevens-Johnson syndrome, SJS, from toxic epidermal necrolysis, TEN. SJS involves less than 10% BSA. TEN is the catastrophic extreme, jumping to greater than 30% widespread full-thickness necrosis. And notice how both differ entirely from staphylococcal scalded skin syndrome, or SSSS, which is toxin-mediated and very superficial. You absolutely must recognize this specific presentation the second you see it. Check out the intense mucosal involvement here. Mucous membranes, the eyes, mouth, genitals, they become severely eroded and hemorrhagic in over 90% of SJS and TN cases. It's a massive hallmark feature. If you're looking at widespread dusky red macules, a positive Nikolsky sign, and this kind of severe mucosal erosion in an adult, well, your internal alarms should be absolutely ringing. Now, here's a classic diagnostic trap that frequently ends up being a fatal execution gap. Do not confuse SJS and TEN with staphylococcal scalded skin syndrome. The trap is confusing an immune-mediated drug reaction, typically hitting adults, with a toxin-mediated pediatric infection seen in kids under 6. Plus, SSSS lacks those targetoid lesions and severe mucosal erosions. Mixing these up will completely derail your management matrix. And speaking of traps, here's a massive board trap. Do not administer systemic glucocorticoids to a patient with advanced TEN. It's a bad move. Steroids just increase the sepsis risk and overall mortality without actually altering the apoptotic trajectory. Let's pause for an executional pearl, absolute barrier failure, and volume resuscitation. The single most dangerous execution gap when dealing with massive epidermal sloughing like in TEN is failing to respect the resulting thermodynamic and hemodynamic collapse. As the source material bluntly puts it, these patients have the exact same complications as severe burn victims. Do not sit around waiting for a formal biopsy report to confirm TEN. The structural consequence is absolute barrier failure, and that induces massive unmeasured insensible fluid loss that will precipitate hypovolemic shock. Early diagnosis, immediate discontinuation of the offending drug, and aggressive IV hydration in a dedicated burn unit, those are absolutely uncompromising requirements if you want them to survive. All right, jumping into Module 3, Melanocytic Malignancy Kinetics. Let's talk about biopsy architecture. We need to audit the procedural diagnostic failures associated with pigmented cutaneous lesions. So, think about this Socratic question for a second. What is the fatal biopsy mistake when evaluating a highly suspicious melanocytic lesion? A clinical lawyer might try a quick, superficial procedure just to get a piece of tissue. But I want you to seriously think about what is permanently lost if you just shave the top off and transect the base of a potential melanoma. The execution protocols here are completely black and white. You must perform a complete excisional biopsy with appropriate narrow margins, usually 1 to 3 millimeters. A superficial shave biopsy, that is the fatal mistake. Why? Because it transects the base of the lesion, completely destroying our ability to measure the exact depth of the tumor. An excisional biopsy preserves the entire architecture, from the surface all the way down into the deep dermis, which you absolutely need for staging. This pathology variance box isolates the exact metric that dictates destiny, the Breslow thickness. This is the definitive depth of invasion, measured microscopically in millimeters from the top of the granular layer down to the deepest tumor cell. It is the single most critical prognostic parameter for staging malignant melanoma. It dictates survival odds, it dictates necessary surgical margins, and it dictates sentinel lymph node biopsy eligibility. If you transect the lesion with a shave biopsy, you destroy the Breslow thickness. You're essentially flying blind into cancer management, and that's unacceptable. Okay, time for our mandatory clinical validation drill, testing execution under pressure. We're going to test your immediate reflex execution on everything we've just audited. Let's look at Vignette 1. A 42-year-old male presents with painful, flaccid blisters across his trunk, extensive oral erosions, and a positive Nikolsky sign where the superficial layers separate with a slight rub. Okay, based on those flaccid physics and the mucosal failure, you should immediately recognize pemphigus vulgaris. But what is the specific microscopic target architecture? The answer is desmoglein, specifically 1 and 3, causing an intraepidermal cleavage plane. Now for Vignette 2. A 64-year-old female develops a widespread rash with raw mucous membranes 2 weeks after starting a suspect drug like allopurinol. Examination reveals sheet-like desquamation covering 35% of her total body surface area. What exact clinical threshold has she crossed? Well, based on that greater than 30% surface area detachment metric, combined with the mucosal involvement and drug exposure, you are looking straight at toxic epidermal necrolysis. This chronology map basically reorders her findings into a real-world timeline of rapid decompensation. Step 1, it starts with the exposure to the offending agent. Think sulfonamides, allopurinol, or seizure meds. Step 2, it progresses to a prodrome with targetoid macules and mucosal erosions. Step 3, it escalates to confluent epidermal detachment, crossing that 30% threshold and officially becoming 10. And finally, Step 4, it leads to unmeasured insensible fluid loss precipitating hypovolemic shock. I'm going to leave you with this final assessment to keep you in an active clinical mindset. For a patient presenting with greater than 30% BSA epidermal sloughing and hemodynamic instability, what is the single most critical, uncompromising next step in management? Think about the burn unit, think about massive intravenous fluid hydration. You must recognize the barrier failure and execute the protocol without a second of hesitation. The barrier is gone and the clock is ticking, so are you ready to execute?